All right, we're going to go ahead and get started. Thanks to everyone for joining us today. I know it's been an exciting day, and I want to start by acknowledging this historic moment in time as we now have our first Black South Asian female identifying vice president, who was installed during a ceremony filled with beautiful music, amazing poetry, and a renewed appreciation of science. And so as the country turns its attention back to science, so must we. And thus, it's my pleasure to introduce Dr. Melody Goodman. Dr. Goodman is a biostatistician and research methodologist who focuses on identifying origins of health disparities and developing, as necessary, evidence-based primary prevention strategies to reduce these health disparities. Dr. Goodman is the Associate Dean for Research and Associate Professor of Biostatistics in the School of Global Public Health at New York University. She received her BS in both Applied Mathematics and Statistics and Economics from Stony Brook University. She then earned both her MS in Biostatistics and her PhD from the Department of Biostatistics with minors in Theoretical Statistics and the Social Determinants of Health from Harvard University. Dr. Goodman has over 100 peer-reviewed publications and 2 books about research methods in public health. She's also written one of my top 5 most shared papers, multivariate or multivariable regression, which you can find in the American Journal of Public Health. And she's received funding for her work from a variety of sources, representing the diversity of her research, including the National Institutes of Health, the Robert Wood Johnson Foundation, the Verizon Foundation, the Long Island Community Foundation, the Patient-Centered Outcomes Research Institute, PCORI, and the Susan G. Komen for the Cure Foundation. Dr. Goodman has won awards for her research, her teaching, and her leadership, and we're so fortunate to have her with us today. She'll be speaking about the science of stakeholder engagement, development, and validation of evaluation metrics. Thanks for joining us, Dr. Goodman.
Thank you for having me, and thanks for that introduction, Dr. McClure. Excited to be with you guys on a day where I cannot stop smiling. People who know me know I do not smile this much, but today has just been a day where I'm smiling so much my cheeks hurt. So I'm excited to talk to you today. I'm going to share my screen. Hopefully that everyone can see. And I'm going to sort of jump right into it. There's an African proverb that says, if you want to go fast, go alone. But if you want to go far, then go together. And I think this really sums up people who do community engaged or stakeholder engaged research. We know this work is not fast, but often it lets us go further than we would be able to go without it. So I'm going to talk a lot about community engagement or stakeholder engagement, and I'll use those words interchangeably. But I'm going to work through the working definition of community engagement from the CDC. And they define it as the process of working collaboratively with and through groups of people affiliated by geographic proximity, special interests, or similar situations to address issues affecting the well-being of those people. It is a powerful vehicle for bringing about environmental and behavioral changes that will improve the health of the community and its members. It often involves partnerships and coalitions that help mobilize resources and influence systems, change relationships among partners, and serves as catalysts for changing policies, programs, and practices. So when I talk about community engagement, I'm really talking about working with groups of people. And sometimes they are affiliated by geographic proximity, but not always. And maybe they have some other affiliation. So why do people do stakeholder engaged research? Well, I think that it really ensures that your work is patient or community centered. And that non-academic stakeholders provide unique perspectives on needs that often researchers don't think about. So this increases the relevance of the research that we're doing for non-academic stakeholders, whether those be patients or communities or policymakers and the like. It also supports the sustainability of interventions post-funding and builds capacity and trust among all stakeholders. It allows research teams to leverage the existing resources within the community or the population that they're working with. And it's done well, it creates reciprocal relationships between researchers and non-academic stakeholders. And it's been shown to be an evidence-based approach for addressing health disparities. So my work is really focused on measuring partner engagement. And I'm not going to get on my soapbox yet, but I think this is really important. And it was driven by the fact that the extent to which stakeholders in research partnerships feel engaged has really not received sufficient attention. And we thought it was important to understand how engagement level in a partnership is developing, but really also to what extent is engagement level in a study predictors of outcomes in the larger study, whether that be the diversity of the population recruited or the speed of recruitment, the dissemination efforts, and the like. So I'm going to walk you through our approach, and we started off with a systematic review. We then developed the initial version of our measure. We've been working to refine and validate this new measure. Also developed a shorter version of the measure, which we think will be used in practice. We've been fiddling with a computer adaptive algorithm, and we ended with an implementation study trying to get people to use our measure in practice. So I'm going to show some papers that we've already published. There's QR codes on all these papers. And my data analyst in her smartness put these up so you can scan the QR code or take a picture of it, and it will take you to the link to that paper. So our first paper was a systematic review of quantitative measures of stakeholder engagement. And it was sort of a large undertaking, but we really thought that um, there would be some measures in the literature. So we started by thinking that such measures existed and had properties that were understood. But when we did our systematic review, what we found that lots of people had measured something, but it wasn't really clear if they even knew what it was that they were measured, and the field itself just wasn't really strong methodologically. When we did our systematic review, we found that existing measures came in two camps. One in which investigators simply counted the attendance in various events and activities and assumed engagement. So the number of people who attended a meeting or the like. And what I know from my own engagement work is just because someone is there, it doesn't mean that they're engaged. So attendance is one thing, and that's important. But engagement is much harder. So um, we just didn't think that attendance really counted as engagement, but probably almost half of the measures we found were attendance type measures. And the other sort of camp that measures came in is which investigators measured some construct that was possibly related to engagement, but we didn't really feel like they were measuring engagement, at least in the way that we wanted to. And one example is one of the measures was assessing the degree to which participants felt comfortable sharing their thoughts and opinions. For the majority of the literature, whether they were sort of counting attendance or measuring constructs, there was very little validation of this literature. Most of the engagement measures had not been examined in relationship to outcomes or progress in a project, and they had not been tracked over time. And this was really important to us because for our own work, this is what we were interested in doing. So we developed our initial measure. And I'll be quite honest, this work came out of the Program for Eliminating Cancer Disparities at Washington University in St. Louis School of Medicine. At the time, we had a center grant that had research projects and pilot projects. Excuse me. It also had community partnerships and an advisory board. So it had many sort of different types of engagement. And in fact, the RFA for this center required us to do an RCT using CBPR. And so those of you who know about RCTs and CBPR know how much of an oxymoron that is to have to write a grant like that. But that was sort of the structure of this grant. And then NIH came to us and they said, well, can you show us that all this engagement was working? And we kind of thought, well, you told us to do all this engagement in the grant. We weren't really measuring that. We were measuring other things. And when we initially got this request, we thought we would just go find a measure, add it to our annual evaluation survey, and sort of fulfill this requirement. Um, but we couldn't find anything. And so we were sort of developed our own. And so I've been working on this now for several years. Um, so the measure that we developed, and we used a community academic partner approach in our development. We worked a lot with the PCAD advisory board, which is called DEEC, the Disparities Elimination Advisory Committee. And we went to the literature and we looked at the principles of community-based participatory research, principles of patient-centered outcomes research. We went to community campus partnerships for health and looked at their principles around engagement. We looked at principles for stakeholder engagement. And we sort of came up with this list of 11 engagement principles that was vetted by our advisory board, and decided to develop our measure around these 11 engagement principles. Each principal is measured by 3 to 5 items. They have Likert type response options, and they're measured on 2 scales. This also came from our community partners who talked about the fact that quantity and quality was important. They were clear that you could do something poorly a whole lot, and something really good but not that often, and that it made sense for us to measure both. So we measure both on a quantity and quality scale. So Dr. Pagano at Harvard was one of my mentors, and so the historical side note is a function of having been mentored by him. But Dr. Lickard taught at NYU from 1930 to 1935, and he invented the Likert scale in 1932, which meant it was invented at NYU. This picture of this work is from the NYU library, a scan of the original paper. Um, Looking at Likert scales. Those of you who know him, he was a fellow of the American Statistical Association, and he was also served as president. But what most people know about him is that he demonstrated that a single streamlined question with a scale set of answers was ideal for standardized type questions. So after we did our literature review, systematic review on measures of stakeholder engagement, one of the things that we really thought about was the fact that lots of people were probably doing engagement work, but not necessarily publishing or necessarily evaluating that work. So Vetta Thompson and I wrote this commentary or position paper trying to get the field to sort of think about stakeholder engagement as a science and to really start publishing the work that they were doing in terms of how they were classifying their work, how they were implementing their work, and more specifically, how they were evaluating their work. And so we think it was effective because we got lots of not so nice emails in exchange for our commentary. And that's partly because we put this figure in our paper, and it was adapted from the literature with these bins that had already existed around non-participation, symbolic participation, and engaged participation. And we just sort of put some categories to these bins. And people who were doing outreach and education type work were really offended that we called that non-participation. But I'm going to talk about that a little bit more later. But this was sort of our original thinking, that outreach and education were non-participation, that coordination and cooperation were sort of symbolic participation. You're bringing people to the table, but maybe you're not really engaging them in ways that is really important. And that engaged participation was collaboration, whether it be patient-centered research or community-based participatory research. And so subsequently, we were funded by the Patient Centered Outcomes Research Institute to really refine and validate this measure that we had developed. And so these are the aims of our project. And I'm sort of going to walk you through some of the work that we did. And PCORI really gave us an aggressive timeline. We had a 3.5 year grant, even though they asked us to add an additional aim to our original proposal. And they asked us to add the implementation part, which I'll talk about later. But like most people, as we were implementing, the COVID-19 pandemic hit. And so that's the worst time to be in the implementation phase of your study. But I'll talk about how we made it work. So the first part of our study, we used a Delphi process. And for those of you who don't know, the Delphi technique is a method for collecting and organizing informed opinions from a group of experts using an iterative process. And it's often used in survey development. This approach is most appropriate to ensure that feedback is obtained from all stakeholders, with all stakeholders treated equally and everyone's voices being heard. This was particularly important to us because our Delphi panel consisted both of community health stakeholders and academic researchers, and we wanted to make sure that we were treating all voices equally. This Delphi technique really afforded us a stakeholder engaged measure development and validation process. And we use web-based surveys for most of the rounds, rounds 1, 2, 3, and 5. But for round 4, we had an in-person meeting. We used some polling software live to sort of see where things were. But it was really great to sort of talk things through with the participants. So the responses to the surveys were analyzed by the investigator team and returned to Delphi panelists for further consideration. And subsequent rounds include items where there was not consensus, and it accompanied anonymous feedback from previous iterations. And this feedback was really nice because it showed the panel's own response. It showed the average response of all the other panelists, but it also showed them the responses stratified by whether panelists were academic researchers or community health stakeholders. And panelists are encouraged to reconsider their previous responses and, if appropriate, to change their previous responses in light of the replies and comments from other panelists. The eventual outcome of the Delphi process is to reach consensus. In our study, we said that that would be 80% of agreement amongst experts. However, consensus is not forced. So items for which consensus could not be reached were discussed in the in-person meeting. And on day 2 of the in-person meeting, we actually received 80% of agreement with live voting from the participants. So this figure sort of walks you through our Delphi process. We started in June of 2017, and we completed in August of 2018. We did webinars or presentations to sort of prepare the panelists for each round and talk about the summary of findings. And we also gave them a heads up of what we were looking for. And one of the main tasks of this Delphi panel was to reduce the number of items, which I'll talk about in a bit. So we started with 48 items. And so those of you who do research know that 48 items for one measure is a non-starter. No one would ever use a measure that had 48 items unless that was going to be their whole entire survey. And so through each round, we really kept track of how many items were not changed, how many items were dropped, how many items were added, although we were conscious not to add too many items. So there was a high bar for an item to be added, um, and how many items were modified. Going from round 1 to round 2, we actually really thought through the engagement principles. And so we moved from 11 engagement principles down to 8 engagement principles. And we were able to move to reduce the number of items from 48 to 43. And you'll see through each rounds, we were able to sort of drop a few items, although not as many as I would like. So we were down to 36 items by round 3. We had 33 items that we started with before round 4. And we on our final version of the measure still has a lot of items. It has 32 items totally. These are the members of our Delphi panel that attended our 2-day in-person meeting. I have to give them a big thanks. They really contributed to our science in ways that you could never put in a grant proposal or any type of publication. We invited them to New York City in April when it's actually nice to be in New York City, and we kept them in a conference room with no windows for 2 days. And they sat and they talked about engagements and measurements and all the nerdy things that I love to talk about. And so I'm immensely thankful to all of our panelists. And so we've been releasing papers, as I said. And so one of the papers we released was sort of this process of how we work to reach consensus on which principles of stakeholder engagement in research were important to measure in a measurement tool such as this. And so we have named our tool, we call it the Research Engagement Survey Tool, or the REST for short. And it is based on 8 engagement principles: focus on community perspectives and determinants of health, partner input is vital, partnership sustainability to meet goals and objectives, foster co-learning, capacity building, and co-benefit for all partners, build on strengths and resources within the community or patient population, facilitate collaborative and equitable partnerships, involve all partners in the dissemination process. And the eighth EP was one that was added, which was build and maintain trust in the partnership. It wasn't in our original 11 engagement principles, but through our Delphi process, it was one that we thought was really important. The other ones are all modified versions of ones that we started out with. And so we've also been thinking about the content validation. So that's sort of what this Delphi process was to sort of validate both the engagement principles and the measures themselves. One of the things I will say about this process is um, definitions became so important, and we didn't expect that. So we thought that if we put up an engagement principle, everyone could agree on what it was. But the only way that we were able to reach consensus is to also have a definition that people could agree on. So for each engagement principle, we also have definitions that correspond to those principles, as well as the 3 to 5 items. And the other thing I will say is that we brought an editor to our in-person meeting, which for me was really helpful because she was able to help suggest some language that I think really helped us reach consensus around some of the items. So the next phase of our research, which sort of was happening in parallel to the Delphi process, were community engaged research participant surveys. And this was us testing the measure among people that had participated in community engaged research. And this was a longitudinal web-based survey. It consisted of 4 surveys. We released our first survey in July of 2017. And our last survey in January of 2019. You'll see some big gaps there, but particularly a big gap, almost a year between the release of Survey 3 and Survey 4. And I'll talk to you a little bit about what we were doing in that period. But you'll see that all of the surveys had over 300 people respond to each survey. We had over 300 responds to all 4 surveys. And obviously, we saw some attrition over time, but considering how long it took, the attrition seems reasonable. Between Web Survey 3 and Web Survey 4, one of the things that we were focused on was conducting cognitive response testing. And this was really important because even though we had a stakeholder engaged Delphi panel, one of the things that we noted was that most of our panelists had a really high level of education. And we wanted to make sure that we were developing a measure that could be used in general populations. So the purpose of the cognitive response testing was to ensure readability and understandability of the measure. And the results suggested that there were some literacy and interpretations concerns around certain words. I would say it was more interpretation and less about literacy, but what we meant when we said dissemination and governance and intellectual process and things like capacity. So people know what those words meant, but they didn't really understand what we were trying to get to in the context of our question. I think the cognitive response testing was also helpful in terms of the stem of our question. um, it allowed us to sort of fix that and revise it to something that people sort of find useful. Um, in trying to reach consensus, one of the things that we did, which violates principles of survey building, was we ended up with these complex questions with a lot of lists and a lot of ands that we ultimately had to get rid of. And even though we study survey methodology, sometimes when you're trying to reach consensus, you're willing to sort of violate some things, but we ended up having to go back and fix those things. And the other thing we sort of got out of the cognitive response testing was to add a non-response or non-applicable response option. And as a statistician, I really struggle with this because not applicable to me and translates to no data. But I think in this case, it was really important because there are parts of our measure, such as engagement principle 7 that focuses on dissemination, where if your project has not reached a dissemination phase, those questions really are not applicable to you. So we added a non-applicable response option and made all of these modifications from the cognitive response test, which ultimately went on the final web-based survey. So in our final web-based survey, we had a good mix of Black and white participants. We didn't do so well with Latinx or Asian. And the majority of our participants were female. We were really concerned about this, but we talked a lot to the PIs that we've been working with, and many of them mentioned that a lot of their community partners are female. So we actually think this is probably fairly representative of the population that we were trying to reach, although probably some gender skew, and pretty well educated. We originally thought that we would only sample participants from New York and St. Louis. But one of the things that sort of came up in our Delphi process was that how people talk about engagement is different depending on where they are. And we were really trying to develop a measure that was generic to population, to geography, even to disease, mainly because there were no measures that are out there. I mean, I think eventually people will want tailored measures, but when there's nothing out there, you want to create something that lots of people can use. And so we expanded our enrollment across the US and US territories. So it was nice to see that the participants in our survey had collaborated with 177 universities. Here I'm just listing those that had more than 15, and obviously I was at Wilson and I was at NYU, but it was nice to see University of Alabama and Northwestern and Mayo Clinic sort of step up and give lots of participants, even though they weren't affiliated with our study. So one of the things that we wanted to measure in terms of validity was the internal consistency of our measure. And so we used Cronbach's alpha, which is a statistic calculated from pairwise correlations between items, measures whether several items that propose to measure the same general construct are consistent. And so for us, we were interested in, do items that are aligned with the same engagement principle, are they internally consistent with one another? And typically values greater than zero point 0.7 is acceptable. So we looked at this for both of our scales, quantity and quality, by engagement principle, and we see strong internal consistency across both scales. The next thing we wanted to do was to look at correlative validity. And we use Spearman's correlation coefficient, which is the non-parametric counterpart to Pearson's correlation coefficient, and sort of interpreted the same way. And so we were really interested um, in, so when you're trying to create a measure for which there is no gold standard, you're taking different approaches to try to validate this measure. And so correlative validity was one of the approaches that we took, because we thought, does our measure correlate with other types of measures that we think it should correlate with? So we looked at things such as medical mistrust, trust in medical researchers. There's a community engagement and research index. There's a partnership assessment and community-based research. And there's a coalition self-assessment survey that has multiple scales. This happens to be the trust scale, which we correlated with our trust subscale, which is engagement principle 8. And here you'll see that all the correlations are significant, but on this slide, they are negligible or low. And on the next slide, they are moderate. This is a measure developed by Kagan. There's a synergy scale of the PSAT. There's a satisfaction scale of the PSAT, which we use, and we also use a measure by Wilder. I'm actually really excited by these findings, because I'm happy to see that our measure is correlated with other measures, but not highly correlated. So to me, this suggests that we're measuring something that is related to all of these other measures, but not the same thing, so that our measure is actually unique, which is good, because none of these measures themselves are measuring community engagement in the way that we wanted to measure it. The other thing that we have been working on that I mentioned before, sort of classifying levels of engagement across a spectrum. And so this is a follow-up to that commentary that we wrote at first, um, talking about these strategies for engagement and research, and how we defining and classifying engagement. So I showed you the first figure that had sort of stacked non-participation, symbolic participation, engaged participation. And then we started really thinking about engagement as a continuum. So you sort of start in one spot, and sort of there's a continuum. And I think this is important, because I think people got offended because their projects weren't all categorized as partnership or collaboration. But we weren't suggesting that every project needs to be in that space. We were really trying to get people to think about, what research are you doing and what level of engagement is appropriate for that type of study. For example, if I'm doing secondary data analysis with an existing public use data set, I don't need a high level of engagement. Maybe I want to talk through what variables I should choose or the like, but I don't need a high level of engagement to do that type of study. Whereas if I'm trying to do some intervention research, then I may want a much higher level of engagement. So this was sort of our thinking, because if you ask a biostatistician, or at least if you ask me something, I'm going to think linearly, because that's sort of what I've been trained to think. And so we really looked at how our measure was lining up with what we thought the sort of continuum of community engagement was. And one of the things that was sort of intriguing to us was that outreach and education sort of outperformed what we were calling consultation, and in some cases cooperation, even though in our mind, it was a less engaged level of research. And it really made us think through this idea of it being a continuum. So what happens if you move from a continuum in your biostatistician? You move from one axis to two. But I do think this thinking, outside of helping me make this clearer in my mind, became really important for us to distinguish, and that is, we were thinking about engagement in terms of what non-academic partners input into the research process. But we hadn't been thinking about it in the way in terms of what academic researchers output to the non-academic partners. And so when you think about these two scales, outreach and education, while there's not much input, there is in many cases a lot of benefit out. And so this thinking helped us align with what we were seeing in terms of our data, and really thinking through the two axes, I think, more concretely about things going out and coming in, because that's really what makes partnerships work. So, to reduce partner burden, we wanted to develop a condensed version of the measure. And so we considered several methods in determining which items to cut out. One of the things we looked at was the amount of not applicable and missing responses. We also did a factor analysis looking at cross loading, non loading, and low loading items. We looked at the distribution of responses. We looked at item response theory results, slopes, and threshold rankings. We looked at item importance and difficulty rankings from the cognitive interviews. And from the Delphi panel, we looked at how they rated each engagement principle in terms of importance. So we were really trying to triangulate here using data from both quantitative data we had collected, and also some qualitative data, and also transformative data, which is my new love, which is when I take qualitative data and figure out a way to get quantitative data from that, and trying to sort of come up with which items we think um, should be dropped. So results show promise for a 9 item version of the measure, which is reduced from 32 items. And we actually think a 9 item version of our measure people will adapt and use. And the condensed version is highly correlated with the full version, both overall and even at the engagement principle specific levels. And so this sort of shows you our condensed version, how it's comparing in terms of it still has strong internal consistency. And you'll see that the means and medians are close on both the quantity and quality scales, and that it's really correlated with the comprehensive version of our measure. And we looked at multiple condensed versions, and they all sort of performed well. We picked one ultimately, but you'll see even at the EP level, the means of the condensed version are really close to those that we see from the comprehensive version. So we really are excited about this 9 item version, because we think people will use it in practice, and it performs well to what we've seen to our comprehensive version. One of the other things that we started working on is looking at differential item functioning by demographic characteristics for the 9 items in our condensed version. And we looked at this by gender, race, ethnicity, just broken up into non-Hispanic Black, non-Hispanic White, and other, just because of sample size issues, and education, college degree or higher, and less than college degree. So one, I'll say that these cut points are not ideal, but they're necessary for our sample sizes to look at them. And so what we did is we sort of did an ordinal logistic regression model. And in the first model, the item is the outcome and the score is the predictor. And in the second model, We look at the item as the outcome, the score as the predictor, and the demographic variable, for example, gender, as a potential moderator. And we conducted likelihood ratio tests comparing -2 log likelihood from two models using a chi-square distribution with 2 degrees of freedom. And if the result is significant, then there's evidence of differential functioning. And this was an iterative process of testing different items for each engagement principle across demographic groups until there's no further evidence of differential item functioning. So for the quality scale, we really only saw 2 items where there was an issue with differential functioning, and we were able to swap out those items with other items where that was not happening. For the quantity measure, there were 5 items that we were focused on. And again, we were able to find other items in the same engagement principle that we could swap out. And then differential functioning was no longer an issue. And this adapted version of the measure is looking pretty well compared again to our comprehensive version of the measure. It still has strong internal consistency and is highly correlated with our full measure. We pilot tested this adapted measure in amongst the partners of this research team. And so we had 29 people complete the survey, and the results show that the adaptive measure works. I'm not in love with it yet, the way I'm sort of in love with the comprehensive and the condensed versions. But I'm told that you will love all your children, and I feel like this project has been my baby, and so I'm sure that at some point I will find more love for this. It's just not functioning completely the way that I want it to, and so I really want to test it a little bit more to make sure that it's working properly. But it still performs really well. And again, this is a much smaller sample, so I think I probably need some more data to make me fall in love with this. And so the last part I want to talk about is our implementation study, which we just recently completed. And the purpose was to evaluate the stakeholder engagement measure in practice, and examine the implementation and performance in currently ongoing or recently completed patient centered outcomes research or comparative effective research studies. And we wanted to examine the uptake among research teams, barriers, and facilitated factors for use of the research engagement survey tool in practice, and also get some best practices for implementation. So we use the consolidated framework for implementation research, which is comprised of 5 domains: intervention characteristics, outer setting, inner setting, characteristics of the individual involved, and process of implementation. And this information has been used to refine the tool administration guidelines, procedures for implementation of the tool in practice, and it's also helping us figure out how to package and disseminate the tool to be used by research teams. As I mentioned previously, so COVID really happened while we were in the midst of this work, but I really thank the teams that work with us on this. I think it still came out to be really good. So we had 86 teams complete our baseline survey. 36 of those teams indicated that they would be interested in implementing REST, and then COVID happens. But we actually had 20 teams continue with us even during shutdowns and the like. And the nice thing about the 20 teams is they had 26 projects in total. So a couple of teams had more than one project. There was a median of 5 partners per team, but it ranged from 1 to 26. And the stakeholder partner survey went out to the partners of those teams, and we had 178 of those teams partners complete the REST measurement. Project teams could indicate on their baseline survey whether they would like a detailed project specific report on REST, a comparison report comparing their study to the average of all the other studies in the team, and even if they wanted their raw project specific de-identified data. For teams with at least 5 partners completing, they were given materials as requested. If projects had less than 5 partners completing, they were given a full summary report of all the teams. We didn't give them their individual data. We just didn't want to identify anyone. And then we did follow-up web survey and Zoom interviews. So all teams who implemented the REST completed the follow-up survey. And then a little more than half of our teams, or 65%, completed a qualitative interview via Zoom to really talk about both the implementation of the rest, but also the report they received, the data analysis, like really did they understand this tool and how useful was it for them in practice. So it's been really nice to see teams use our measure. I mentioned as a biostatistician, it's very rare that people are chomping at the bit to use something you're working on. So it's been really nice that people have been using it even as we've been developing it. But a big thank you to the teams who participated in our implementation study. So please don't blame PCORI or the board of directors or anyone for anything that I've said in this presentation. And I really want to thank my colleagues, those who worked on the systematic review, and those who've worked on the PCORI project. This has been some really exciting work for me to do. Um, these are just references for all the measures that we compared our measure to in the correlative validity assessment, and I'm happy to take any questions.
Thank you so much, Melody. That was great and really interesting. And of course, my dog just started to growl, so I will try to like mute in between when. Um, so if you have questions, please put them in the Q&A box. I know there was one question that was answered through the course of your talk already. And the question that's there now is just with citations. I think you presented those at the end. Are there other questions? So I guess I'll ask the newer version. You said you didn't love it yet. So can you talk a little bit? I mean, you said it's not performing. What would you like it to be doing that it's not, or what would make it make you fall in love with it? I guess.
I don't want to say that it's not performing well. I think it's because I really only have data from 29 participants. And so I just don't really have the variability of responses that I want to see, but you're not going to get that in a sample of 29. Usually, especially since these were all people that were engaged in our study. So I think we really didn't think, well, obviously we decided to test it on them and it's just a pilot, but we didn't think through our pilot sample in that they were all engaged in the same project, right? And I guess our hope should be that they all rate us really high because it's our study. But what I really wanted to see was some variability. I wanted to see some high and some low. And so I don't love it yet, but it's not because it's done anything wrong. It's just, I think I just don't have enough data on it yet. Like I've been working with the other ones for so long and I have so much data and I know that they're performing pretty well. And this one, I just don't know yet really is the issue.
Great. So um, yeah. So there's another question, another couple of questions. Let's one participant says that she loved really liked your presentation and liked seeing the differentiation between quality and quantity. Do you have any thoughts about disadvantages or downsides to this approach, though?
So we talked a lot with our community partners about scales and measurements. And we didn't really come up with any better alternatives. So no, I don't think our measure is great. But I think it's the best that we sort of could come up with. And I think what we've seen from the data is that it is, as our community partner said, it is important to have both because you don't get the same scores on quantity and quality. And there's a story in that, right? And I think lots of people think if I do something a lot that I'm doing well. And one of the things that we see in engagement is that that is absolutely not true. Just because you're doing something a lot doesn't mean that people perceive that it's great. Or just because you're doing something a little bit doesn't mean that people won't perceive that it's great, right? And so having those two numbers, especially when they diverge, has been a really, I think, conversational point for project teams to sort of think through their approach. And I also think, I've been sort of pushing for engagement to be a science. And if you're going to develop evidence based approaches, you need some empirical data to sort of start to support the techniques you're using and the approaches that you're using. And I think you need more than one data point, right? If this is sort of a new science, you sort of need more than just sort of one thing. And I think teams that have been grappling with this quantity quality thing have really started to think about, I think, their engagement in more meaningful and purposeful ways.
Thank you. Some more questions are coming in, so I'm going to try and group them if there's ways to do so. One attendee wondered, could the measure be applied to politically organized groups to assess engagement?
So yeah, we have developed our measure so that it focuses on partner engagement, whoever your partners are. We haven't used it in that sort of space, but we have used it with health departments and health systems and other types of stakeholders that are not patients or community stakeholders, and it's performed well.
And similarly, there's a question about adapting it to other types of engagement processes.
I don't know what they mean by it. Can you give me some clarity on what that
Uh,
means?
I'm not sure either. It just says thoughts on adapting it. We can check. It's Dr. Bellamy. We can check with her later and see. Um, so a couple of different questions, and I'll let you decide which way you want to go first. One question about just more details about the success of gathering data during COVID. And the other is also somewhat of an implementation question about, is there an approach to helping organizations improve their level of engagement if they don't score well on the measure?
So, I think we were lucky that our survey, our research was already web based for the most part and remote, and we had really finished the in person parts pre COVID. So our implementation phase was already web based and remote. I think the challenge was we really went into the field in March, and people just were so uncertain and didn't want to commit or add one more thing to their plate. But on the other side, there were some teams who were like getting ready to evaluate their work, and it was the timing just was perfect and it worked. And so I think we were able to find some groups that it really worked with. I am concerned a little bit about the bias in that sample. I don't know if that's just a statistician in me of like, are people who were able to make it work during COVID somehow different than partnerships that weren't able to make it work? But we did ask them some additional questions about how COVID was impacting their partnership. So we haven't analyzed all that data yet, but I think we'll get some data to sort of understand how unique or not these sort of partnerships were from other partnerships. And I forgot the other part of that question.
The other part was, are there mechanisms for engaging organizations if they're, or for helping organizations if their level of engagement is low on the scale?
So our measure doesn't do that. We're trying to assess the level of engagement, but one of the things that we are sort of working on disseminating now is I've shown you means and how our measure performs, but the other thing we've done is to actually align our measure with those categories of engagement that I was showing you. And we have a alternative scoring system that sort of aligns with those engagement categories, and it's more like it doesn't put your project into one category, which was what we were thinking about first, but it's actually more like a 23andMe report. So it'll say like your project is 5% outreach and education and 20% collaboration and 10%. And so because it's more of a realistic assessment that many partnerships are not just in one place, that different parts of the partnership are doing different things. And so you sort of get an assessment that gives you sort of percentages for each group of how your partnership sort of aligns. And people have said that that's been really helpful for them. And I think the partnerships that we worked with in our implementation study, what they really got out of it was this was a great way to start a conversation with their partners about where they are in terms of their current level of engagement, where they want to go, and how they're going to get there. So, no, we're not giving them that advice, but I think partnerships are really starting to think through that based on having some of this data.
Thank you. I think we can revisit Scarlett's question was um, related to the political engagement question. She was thinking about perhaps diversity, equity, and inclusion work. Is there a way, could you use this in that realm to measure engagement now that there's a lot of engagement centered around anti-racism, diversity, and institutional inclusion efforts?
So, yeah, I think so. I think one of the things we really focused on was to have our measure be free of any, like, it doesn't have a population focus, it doesn't have a disease focus. It's really all about partnerships and partners. And so if you're doing any type of work that has a partnership or partners, this measure is appropriate. And we've seen some people tailor it to specific things, and we ultimately think people will go in that direction in the future. But I think developing a generic measure is really been great because I think we've seen people use it in all different ways.
And the next question is along those lines, and I'm sure you're enthusiastic about thinking about adapting this again. But given that we're expecting that we'll continue to relate remotely for a while, engagement may look different and be different for organizations. And do you think that there's a way to consider that in the tool?
So the nice thing about our measure is none of it relies on being in person. So all these things can be used even in a remote space, although we are concerned that remote partnerships will score lower on our tool. We just don't know yet. That's part of the reason why we collected so much data about COVID, because it'll help us stratify and look at some of these things. I don't know those answers yet, even though Picori says I'm done with this project. I'm not really done yet. So we're still analyzing some of our data to work those things out. I do think it has been challenging. So what we saw in some of the preliminary analysis was that partnerships that had a disease focus, some of them fell apart. Some of them transitioned to working on COVID, which has been sort of interesting and sort of kept going. But it's been sort of interesting to watch sort of what's happening to partnerships, particularly ones where all the partners are not Zoom comfortable and like being online is just not a realistic way to convene their partners. We had proposed to Macquarie to create a pandemic version of our measure, which we were going to call the pest, but they didn't buy
Love that name.
it.
Love that name. Okay, so there's a couple more questions. One attendee says, "Thank you for this thoughtful and engaging talk. My apologies if she missed this, but have you reached out to funders and grant administrators to get their thoughts about this and the feasibility of using these results to inform their often very ambiguous requirements surrounding engagement?" So, when funders ask for, so sort of turn this back to Corey, for instance, and say, can we use this in your grants when it requires community engagement?
So yes, Picori's been really interested in this. One of the things we're working on with them is a dissemination grant. So they want us to work with them about how are they going to disseminate this to their grantees or potential grantees. So there's some interest in it from that space. It's also been nice. So NIH has this RADx Up collaborative around COVID testing in underserved populations. And so we are in their toolkit. So teams that are doing that type of work can use the rest, and it sort of has the NIH stamp of approval. So that's sort of been nice. And we hope to get some uptake in use around COVID testing and sort of see how some of those partnerships are faring.
So that's great. That's exciting to think about how it can be used in these different, always changing settings. One person was wondering about whether the tool can be used to sort of parse out, if I'm understanding the question correctly, institutionalized disparities such as health disparities. Um,
So yeah, the tool is more about partnerships and partners. Um, there is some focus on social determinants of health and sort of um, health disparities a little bit, but it's really about the partnership itself, and doesn't really matter what that partnership is necessarily focused on. I think what people find useful about the tool is that it's aligned with those 8 engagement principles. And so in addition to your overall score, you get a score for each engagement principle. And so you can see like we're doing really great at this thing, but not so well at this thing. And I think that's been really helpful for people to think through their engagement strategies about what happens when you rate really high on some engagement principles and not so high on others.
So the last question right now, in case anyone has some more, feel free to put them in the Q&A, is one person was wondering whether there's an index for the measurement so that you can establish an ordinal measure of the level of engagement.
There's not an index for the measure yet. We've been thinking about this, but I think from the implementation work that we did, they were more interested in aligning it with our classifications of engagement. So we've really been going more in that direction. But I think there's lots of things to come out of this. One is I hope it's translated into many languages that I don't speak. And I think, there's a lot of work around that. I don't think it's going to be a direct translation. So I'm not, and so I hope people think about that. But I also think it'll be adapted for certain diseases and communities in ways that we potentially haven't thought of yet.
Great. Any other questions? Well, thank you so much, Melody. It's been such a pleasure having you join us today. And it's a great talk, and we really enjoyed learning from you. So thank you so much.
Thank you for having me.
And thanks to everyone for attending. It's good to see names, although it'd be great to see faces again soon. Everyone take care and be well.